Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned Dr. Harshvardhan Hegre. Sir is an orthopedic director of orthopedic and joint replacement spine surgery at Max Smart Super Speciality Hospital, Saket. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is managing low back pain. Now, without any further delay, I would like to welcome Sir to our forum and would like to hand over the session to him. Over to you, Sir.
Thank you very much. So thank you all for joining in. It's a fairly long topic, but I will try and rush it through so that we get a general idea of what we're talking about. And once we're done, I will be more than happy to address some of the questions that you would have. So this is, I'm working at Max, like Madam said, and I'd be happy to receive any questions at the end of this talk. Next slide, please. So the human spine is essentially a mechanical structure that operates as a system of levers that you would see anywhere in a mechanical garage. It's very well constructed and extremely flexible. So from the time we were four-legged creatures and we became two-legged creatures, the spine not only started playing an important role in movement, also protected the nerves and carried the nerves from the brain down and giving the shape to the back and so on and so forth. So it has the following functions. It's the protection of the spinal cord and nerves, load-bearing, mobility, and posture. Next slide, please. So there are certain mechanical characteristics of the spine. One is sagittal plane. You can see there are three curves. Two of them are lordotic, one is kyphotic. The lordotic curves are in the cervical and the lumbar region, which balanced by the kyphotic curve of the thoracic region. The thoracic is in the middle, such that the head is balanced over the pelvis. Next slide, please. So there are certain, the flexibility of the spine is enormous. As you know, in the chest, there are ribs that are there to protect the heart and the lungs. So the thoracic spine is not as flexible, nowhere close to the cervical and lumbar spine. And both these areas give you a fantastic range of movement in at least 6 different planes. Next slide, please, and a combination of those. So vertebral bodies carry the majority of the weight. So if you remember the anatomy, the front of the spine is the vertebral body, through which goes around 80% of the weight. Next slide, please. Just keep moving on this. The vertebral become progressively larger as you go from the cervical spine to the lumbar spine. They become bigger. And you would remember that in the cervical spine, you got 7 vertebrae, in the thoracic, you got 12. And in the lumbar spine, you got 5, but these are much larger than the ones in the cervical and thoracic region. The front of the vertebrae is known as the anterior column. The back is known as the posterior column. The anterior column, of course, carries a lot of weight. So in between, so this is how the nerves where the red line is are there and they're protected. Next slide, please. Now, we must not forget about the posterior muscle groups. So these are the muscle groups that work. So any joint in the body functions because of the structure of the joint itself and also the supporting muscles around it. If you're talking of the knee, we're talking of quadriceps and hamstrings. We're talking of the spine, then the back muscles and the abdominal muscle, the core muscles, side muscles of the abdomen. This all work in tandem to not only maintain the shape, protect the nerves, but also give us this fantastic range of movement. Next slide, please. So we need to understand the concept of spinal balance because this has got a lot to do with the problem that we are going to discuss as we go forward. So there are two, one is in the coronal, one is in the front. So in the balanced state, the head comes through and balances over the pelvis in both the planes. the frontal and the coronal plane. Next slide, please. So different postures affect the center of mass, but generally do not affect the center of balance. So there is a compensatory change that occurs in the spine in order to accommodate. So in a lady who gets pregnant, or a gentleman or a lady who puts on weight, these are the slightly exaggerated lumbar lordosis that you will see, which will balance the increased weight that is there. Next slide, please. In order to understand the problems, the normal anatomy, then when there is spinal imbalance, and this is essential because all the treatment that we have goes around this. When there is spinal imbalance, almost all pathologies that we're talking about and that we are going to discuss today, whether it's trauma, whether it's infection, whether it's tumor, whether it's degenerative changes, these will all result in some degree of spinal imbalance for the patient to have symptoms. And this spinal imbalance can be in front, where there is a shift forwards and changes the weight-bearing axis. Next slide, please. And this, as we see in the most common presentation that we have, is degenerative changes in the spine, which leads to a change in the weight-bearing axis. And this essentially happens because the weight-bearing axis normally is balanced by the front and the back. And if the weight-bearing axis shifts a little bit towards the back, as the muscles of the back are much stronger than those of the abdomen, especially in people who do not exercise, sit for long periods, etc., then in that cases, the degeneration is faster. And when that degeneration occurs, then you have a sagittal plane imbalance. And that's also seen in fractures, it's also seen in infections that affect the vertebral body, or tumors that affect the vertebral body. Next slide, please. So this is a classic case where there is a tumor which has shifted the vertebra forward. It's the same similar kind of pathology that occurs in trauma or infection. Next slide, please. So this is another metastatic tumor which is looking like that. Next slide, please. So there is sagittal imbalance results in a forward and obviously pain in different areas of the spine, because there's a compensatory mechanism such that the head comes as far as possible over the pelvis. And this compensatory mechanism leads to abnormal postures and abnormal stresses leading to pain. Next slide, please. Then we have the coronal plane imbalance. Now, the coronal plane imbalance is when you look at a person from the front. So this can be because of the developmental issues, especially very commonly seen in scoliosis or degenerative, where there is a scoliotic element. Also can be in cases of tumors and infections and trauma if it results in a coronal plane imbalance. Next slide, please. So this is how they look. So you see a twist in the spine. Normally, when you look at the coronal plane, the spine should be straight. Next slide, please. So where are the pain generators in the spine? The pain generators of the spine are the disc, the nerves, the facet joints, the ligaments and muscles. In order to understand more of the spine, then we should look at one level of the spine, which we call as the motion segment. That is one vertebra below it, and the intervening disc space. Please go ahead. So the motion segment is the functional unit of the spine. And it's very important to understand. It consists of two adjacent vertebrae, a disc, intervertebral disc, connecting ligaments, two facet joints and their capsules. Although spinal muscles are not considered part of the motion segment, they should be included because they play a very important role and they work in tandem. So like I told you, the pain generators are the disc, the nerves, which will usually give rise to radiating pain, facet joints which give rise to a generalized kind of back pain, and the muscles and ligaments which give rise to heaviness in the back, the dispersed pain all over the back. Next slide, please. It's a very common problem, and it's also responsible for many people laying off work change in lifestyle. There's back problems are so much nowadays. It's also responsible for a lot of depression because some of these patients have this constant irritable back pain, which does not respond to most of the treatment. However, the good thing is that almost 85% of them respond to conservative, that is non-operative, non-invasive therapy. And this would be like bed rest, analgesics, muscle relaxants, and then start with exercises and physiotherapy and gradually increase the kind of exercises. And usually this works very well. In some cases, you might have to assist this with nerve root blocks, facet blocks, or epidural injections. So what we do there, we give a bit of steroid around the nerve in a facet block, in a nerve root block, and reduce the inflammation around the nerve such that the nerve has enough space and one is free of pain. If one is free of pain, then one can start exercising and that builds up the paraspinal muscles to support the spine better. Next slide, please. So these are some of the stretches that you could do to reduce the back pain. It's common knowledge, most of them. A good physiotherapist will be able to guide you on that. Next slide, please. And these are some of those common exercises that we see. And this is ergonomic posture that one can maintain in his or her office space with certain, the knees and hips being roughly at 90 degrees, the back being straight, well supported. The monitor is at the eye level, whatever typing one needs to do without really shifting the eyes. If you're a person with back pain or a tendency to develop back pain, one could use like the architect, a kind of sloping surface on which one could put these things. Next slide, please. So one of the common things you would have heard of is trauma. Now, here's a case we've done many years ago. This is a young gentleman with a fractured vertebra, and we had to do a front and back because he was getting paralyzed. So to remove the fragments from the front and then put a cage and put a rod in front and then supported with screws from the back. The patient went ahead to do a near complete recovery. Next slide, please. And this is the anteroposterior view. Next slide, please. And this is a case of spinal tumor where the biopsy had shown a tumor in the spine. We had to resect the tumor en bloc and then reconstruct so that the balance could be well maintained. Next slide, please. So this was what the MRI picture, not very clear. Next slide, please. So this is after surgery from the back. We put screws from the front. We put a cage, screws and rods, and then did a 360-degree fusion. Next slide, please. It did rather well. There's another case where we had resected some of the parts of the vertebra and then fixed it with the screws like this. So these are the cases of tumors that we had done. Next slide, please. Spondylolisthesis. Next slide, please. We missed some slides. So spondylolisthesis is a thing when the vertebra, one vertebra slips forwards on the other vertebra, and that we call as listhesis. And when that happens, the nerves within the spinal canal get stretched along the listhesis area and could lead to neurological deficits, sometimes severe radiating back and back pain, because there is a structural deficiency. So in these cases, you need to reduce the listhesis as far as possible and then fix it and fuse them so that future shifting of the vertebra or worsening of the listhesis does not occur. Next slide, please. Next slide, please. So this is, if you see the lowest lumbar vertebra over the sacrum, you'll see that there is the listhesis and it's slipping forward. It's an open case, so this is an unstable area. Needs to be sorted out. Next slide, please. You can see here in this X-ray far more clearly than on the MRI. the shift is significant. Next slide, please. Next slide, please. So this is how you fix. You use special reduction screws and pull them back and then support the back with screws. And you can see that we put a cage, the level of L5, S1, so that and you can see the shape of the spine has come back to its original rather than a sudden bending there. Next slide, please. So what is the treatment for most of the degenerative back problems, back pain, which is very, very common? Most of the treatment revolves around fusion. Fusion means we fuse one vertebra to the next, whichever is the problematic level. So if there is an L5, S1 problem, then we fuse L5 onto S1 with the help of screws and cages. And we clear the disc space, and within the disc space, we put the cage along with bone grafts, such that the fusion occurs. One of the complaints about this procedure was that it reduced movements. And this is okay in the elderly, but in the young, this can be a problem. So the newer excited area that one came across was motion preservation. Next slide, please. So motion preservation was with the same disc that is there, and you had devices which would preserve the motion, yet in some small way restrict some of the extremes of motion. Or you could just remove the disc like you do in a knee replacement or a hip replacement, take out the disc completely and replace it with an artificial disc. This became a rage some 10, 12 years ago, then slowly went into disrepute. But I think in very selected cases, it works wonders. Next slide, please. So I don't think one needs to go on to the details of this. I think it's a wrong slide with too much of details, but basically it prevents topping off. Topping off means if you fuse L4, L5, then there is a likelihood of L3, L4 going bad because of the fused segment below. Now, this does not happen in an artificial disc replacement because artificial disc restores the movement of that level. So there is no adjacent level disease, and degenerative disc disease like retrolateral disease are also indications for total disc replacement. Next slide, please. So the surgical technique, one need not go into the details, is rather simple. You do an en bloc discectomy. So it's done from the front. So you need to do, take a phenensteel kind of incision, the lower part of the abdomen. And once you've done that, you localize the levels. You need to separate, you need to go extraperitoneal and then reach the vertebra and then separate out the blood vessels. There's a little bit of dissection there. And once you've done that, then you visualize L5, S1, L4, L5. You have to be a little cautious with L4, L5 because that's the area where there is the bifurcation of the aorta and the vena cava. Next slide, please. So this is how it looks like after you've done the disc replacement. I've done somewhere around 400, I think, artificial discs, which is fairly good results. And this is how it behaves. Next slide, please. So this is the anatomical thing for a 4-5. You can see that the path is in the front of the abdomen because you want to access the front and then remove that and put an artificial disc. Next slide, please. And this is what it looks like. And after this, you remove those threads and allow the artery and vein to fall over it. Next slide, please. So this is a gentleman, this is a lady, I think, who came to us with back pain. You can see that she has a disc, the lowest disc, and I thought she was young, wasn't getting relieved. So one other indication is that the person should have a back pain in spite of physiotherapy exercises and living an active life, still the pain continues, then in those cases, you have to consider disc replacement. Next slide. So this is what it looked like. It's fairly stable. Inflection extension. Next slide, please. Yeah, this is the X-ray. Next slide, please. So this is her with the artificial disc. Next slide, please. This is what it looks like on the AP view. Next slide, please. So this, in some instances, especially the 4-5 level, occasionally you cannot get your approach from the front because you're not able to mobilize the aorta and its branches very well. So in that case, you have a possibility of using an oblique approach because some discs can have an oblique approach to position the disc. Next slide, please. So this is one of those cases. Next slide, please. So here you see two levels, one level worse than the other, L5 S1. Next slide, please. The X-ray shows no gross instability. Next slide, please. You can see flexion extension. Next slide, please. So both the levels, the discs have been replaced. And after that, now this is a gentleman who had undergone discectomy surgery twice in the past. Once at the L4, L5 level, the second time at the L5 S1 level. He was temporarily a stuntman for Tom Cruise. And we did this disc replacement. He did rather well, and he continues being the stuntman. Next slide, please. So this is the inflection extension. You can see how well the artificial disc opens up. Next slide, please. So this is what it looked like in front end. So one you can make out, one is the straightforward disc replacement, the other is an obliquely positioned disc replacement. Next slide, please. So here is that if you don't want to go all the way home and do a disc replacement, then you can go somewhere halfway. There are many, many devices, interspinous devices, spacer devices like X-Top, DM, Coflex. There were also facet replacement system top TFAS, etc. But these were not available. The second one, that is total facet replacement, never available. The DM, the X-Top, they worked in some cases, but most of the cases, they were not applicable. Screw-based devices, it started by Genesis, subsequently Graph Peak. And what we have used a fair number is the transition. Next slide, please. So the indications are, it is a moving, nicely healthy disc, fairly healthy disc, mobile segment, without instability. Next slide, please. So here is a gentleman after undergoing disc flexible system. This is about 12 years ago. Next slide, please. This is his bending. Next slide, please. And his extension. Next slide. So it works even in an individual who is rather generous on the weight front. Next slide, please. So this is how it looks like. Next slide, please. So the X-ray shows a kind of empty space. That's because of the flexible rod in between, which is not metal. Next slide, please. So this is a person in whom we had done, we had put a flexible rod. He, at one stage, happened to be the captain of the Iraqi football team. Next slide, please. Look at his range of movement a few days after surgery. Next slide, please. Next. So this is his X-ray, if you can make out. You can't see anything between the two screws. These are the flexible rods that we use, which are, and this is the lateral view, which also shows an absent into inverted commas area. So, next slide, please. We're talking of a very common problem called osteoporosis. Now you can see on the left is a normal bone, trabecular bone. On the right, the trabecular far more far less. And this is what osteoporosis does. It allows for the bones to break without significant trauma. Now, next slide, please. So the story of pathological or compression fracture secondary to osteoporosis is that the pain is unbearable and sometimes it worsens, the contraction worsens. Very rarely, of course, it does cause neurological deficits. But there was a system by which we used to just put in a needle through the pedicle into the vertebral body and inject cement into it. We used to call this procedure vertebroplasty. But vertebroplasty had one major danger, that the cement sometimes would track along the fracture lines and may occasionally track into the canal. And if it did so, on setting of the cement, it's an exothermic reaction. The temperatures are very hot. And if that were to get in touch with the nerves, it would burn the nerves out. So one has to be a little cautious. So the second system to a vertebroplasty was a balloon kyphoplasty. So here what you did is you put a needle, marked your position. On the needle, you put a thickened cannula with a passage, with a clear opening through it. And through that, you do the rest of the work. You put in the balloon, blow the balloon so that you get your original height of the vertebra. And into the empty space that you have created the balloon, you put close to setting cement. So the cement does not have a chance to track along your fractures. Next slide, please. So you can see the 4 steps of the balloon kyphoplasty. Push in the needle, then subsequently put in a balloon through the needle, blow it up, restore the height of the vertebra. You have an empty space. Into that empty space, very slowly, you put cement. Next slide, please. So this is a person who had come to me almost 28, 25, 30 years back with multiple levels of pain because of leukemia. Now his trouble was not the leukemia, his trouble was the pain where the secondaries had spread to the spine, making it weak. And that's why he had broken vertebral bodies. Next slide, please. So that was the case of balloon kyphoplasty. Now here what I'm saying is there is a newer version of this procedure, and it's called as stentoplasty. Now the stentoplasty basically is the balloon kyphoplasty, but now you put a stent before you pressurize it with the cement. So the stent blows up and supports the bone better rather than just the cement supporting. Next slide, please. So you see, next slide. You see, this is what it looks like once you've blown the balloon. Now you empty the balloon and take it out, and you put the stent through that same hole, along with the balloon on top of it. So the company makes it very well. It's a Johnson & Johnson product. And you push it through the same hole, put it in the level you want and blow it. Now this time, you've got a stent supporting the broken vertebra. And that makes it more stable. Next slide, please. Next slide. In some cases, because as we're looking more and more elderly people, you may find unseen fractures which are changing the shape of the spine, which many gentlemen had not complained earlier. In those cases, you might have to use screws, but you have to be cautious that these screws don't come out and cause further infection. So what you do is you put cement through the screws so that the cement develop roots into the vertebral body and augment the fixation a little better. Next slide, please. So this is what it is. If you look at the top screw and the third set of screws, you'll see a halo around it. That's the cement that goes out of the screw. Next slide, please. So this is what it looks like. Fixation. Next slide, please. So minimally invasive techniques. Now, minimally invasive techniques, another thing that you could use, like robotic spinal surgery. Next slide, please. So it has similar outcomes as open procedures. Well, probably decreased length of stay in the hospital. Blood loss is definitely less. And therefore the pain, because we're not cutting open, the pain in the initial stage is definitely less. Next slide, please. So it's applied for all the cases, decompression, discectomy, stabilization procedures, etc. Next slide, please. So this is how it is, a minimally invasive discectomy. So you put a cannula, then you start widening the space. Once you've got enough and you lodged it well, then you carry out the decompression and removal of the disc. Next slide, please. So this is what a T-lift procedure, transforaminal lumbar interbody fusion, looks like when you're using artificial. I mean, when you're using minimally invasive. So the whole procedure is done without cutting too much of the skin. Next slide, please. So this is a case. You can see 4 or 5. Next slide, please. So this is what it looks like after fixation. Next slide, please. So this is our discussion, rather quickly and brief, and I stuck to my time of 35, 40 minutes.
Thank you so much, sir, for your presentation. We have some questions from our audience if you'd like to take that up.
Yes, please. Yeah.
So, sir, the first question from our audience is, what are the current evidence-based guidelines for the treatment of acute and chronic low back pain, including non-pharmacological and pharmacological inventions?
Wow. So this is a lot of answers. So what are the current concepts in the treatment of acute? Now, acute pain is almost always change in lifestyle, exercises, slowing down, maybe resting for some time, analgesics, sometimes support in terms of back support, etc. Now, this is in the acute phase. A chronic, repeated attacks, then of course you need to get MRI and dynamic views to see what is the relationship of one vertebra with the other. And if you find that there is too much of degeneration and quite a lot of shift while bending forwards and backwards, then this is a case which needs to be sorted out. You usually have problems of spinal canal stenosis because of the degenerative changes. And this will have to be relieved because it leads to paralysis in the leg and very rarely, but possibility of paralysis in passing urine and stools.
Thank you so much, sir. The next question from our audience is, what are the potential complications and side effects associated with common low back pain treatment and how they can be managed or prevented?
So, see, the rehab part of it is very, very important in spinal non-operative, even operative cases. One has to be very careful. What is the problem and what are the ways of reducing the risk while doing anesthesia, while doing physiotherapy and rehab. So the physiotherapist, rehab specialist, chiropractor, oblique, all these people need to be well trained in the subject because there is not one magic wand that works for all. One would have to be cautious and consider exercises and rehab, especially with that patient in mind.
Thank you so much, sir. The last question from our audience is, what are the surgical options available for patients with severe low back pain, and how can we determine when surgery is the appropriate course of action?
So I'll come to the second part of the question first. If the pain is persistent for over, say, 2-3 months, if lifestyle changes are tremendous, if there is increasing paralysis, if there is a possibility of bladder involvement. In these all cases, surgery may be indicated. Usually, surgery that is indicated in chronic problems is that of fusion. The young people, the thought of flexible system or a disc replacement comes in. But in elderly, you don't think twice, you do get a fusion done so that the pain is relieved and they're okay.
That's all, sir, from our audience. Before concluding our session, any last remark from you, sir?
Well, back problem is a national kind of all over the world, actually, not only in India, but it's a very common presentation. And it's also responsible for a lot of leaves, a lot of fallout in courses, in jobs and things like that, or slowing down of action. So, and it's a constant reminder, you get pain all the time. And to avoid that, I think looking at means like physiotherapy, exercises, being very cautious with it though, taking analgesic, muscle relaxants, etc., would be the first line of treatment, which would work in majority of cases. Then one could consider injections inside and outside the spine. And after that, if nothing works, then one is looking at surgery.
Thank you so much,